Good morning, everybody. Welcome to our first session today, From Periphery to Power, Scaling the Sex and Gender Health Gap. One of the first things I'll say at the onset here, potential elephant in the room, this is a session about women's health, and I am, in fact, a dude. I don't like it any more than you guys do, trust me.
It's okay, we think of you as one of the girls.
Aw, see, I love it. But one of the things that was interesting, and Andrea, and we'll do introductions in a moment here, you were on a panel yesterday with She Media, and one of the things that Dr. Ashton said was future state, what she would love is this time next year for sessions on women's health, let's have a man up here, right? Because I think one of the first things we want to have people take away today is this misconception that women's health is in fact a women's issue. It is a health issue. Thereby, it is everyone's issue. And as I think about it, I think I have a mother, I have a sister, I have a wife, I have a 4-year-old daughter. You know, their health, their success, all of that is also mine. I play an integral role in that. And I think there is more for the men that are in the audience that we can do to eradicate that misperception that women's health is in fact a women's issue. I would also like to point out, too, for the sake of this discussion, we're going to talk about some health data, some metrics that, frankly, as my 10-year-old stepson would say, shit gonna get real. There's some sad things out there when you look at the data, but we have to accept reality on reality's terms and address these things. We'll talk about progress, we'll talk about hope, but as you hear some of the things that we talk about, I don't want you to get dissuaded by that. I think the proper response to that would be to be upset by some of these talking points. If that leads to anger, let that anger be your motivation. You know, this is an issue, these are issues that we're talking about that in some instances are criminally underfunded. In some instances, we were not looking at women as part of things like clinical trials until a generation ago. So we have made some progress, there is still progress to be made. So if you leave here today and some of what we talk about is upsetting or disconcerting, write your congressman about it, vote on those lines, think about those issues, think about how we can make progress. We will talk a little bit about the macroeconomic and legislative environment, what that means currently, and a lot of these things are not acceptable. You have the opportunity within your communities to go back and be a change agent to motivate change in these necessary areas that we will talk about. So keep those things in mind as we progress today. I want to start, of course, with introducing our distinguished panel here. Next to me, I have Andrea Palmer, CEO of Publicis Health Media, Dr. Shawana Moore. She is the past president, a current nurse practitioner, current educator at Emory University, but also the past president of the National Association of Nurse Practitioners in Women's Health. And then Nicole Benedetto from Organon. That might be your old title that's on there. I don't think we updated the title there. But Nicole, I'll start with you. Just give us the 30 seconds, who you are, why you're here, and thanks so much for being here, of course, but let us know a little bit about you before we jump in.
Sure, yeah. I lead the U.S. Commercial Innovation Organization at Organon, which is a manufacturer of pharmaceutical and medical device products, women's health focus for the company. So that's why I'm here.
Awesome. Dr. Moore?
So I'm Shawana Moore, a PhD in DNP prepare, women's health nurse practitioner, an educator, a researcher, but most importantly, I'm the survivor of a very traumatic birthing experience. So really try to use my national platform to help amplify the importance of women's health conditions. So thrilled to be among my panelists today.
And Andrea?
Yeah. Hi, I'm Andrea Palmer. I'm the CEO of Publicis Health Media, the leading media agency for healthcare industry, part of a bigger holding company, but we handle marketing and media initiatives across multiple different pharmaceutical companies, including my friends from Organon.
Great. So I'm glad you brought up marketing. Wonderful segue to our first talking point here. So as I sit at IQVIA Digital, and certainly Organon, certainly PHM as well, we are in the business of marketing. And one of the first principles of marketing, of course, is you have to know your customer. And the customers in this instance, of course, for our organizations are not only patients, but certainly healthcare professionals such as Dr. Moore. So Dr. Moore, I want to start with you first because you are in a unique position, not only as a patient yourself, as you just mentioned, but as a healthcare professional. You can be the voice of how you interact daily within a healthcare setting, as well as be a voice of your patients within your practice. So I'm curious at the top here, in your years of practicing medicine, where have you observed progress on issues that we would consider traditionally to be women's health? And where do you still see some challenges that are affecting progress within the walls of your practice?
Yeah, so I think nationally we're grappling still with the maternal health crisis across the country. We know that there are inequities and disparities when it comes specifically to women of color. Black women have higher rates of maternal mortality. But of the developed countries, the United States ranks very poorly when it comes to positive pregnancy outcomes for all birthing people. So that's a huge area of opportunity and a huge area that is often not invested in enough. I would say there's a lot of uptake in terms of preventative measures within the women's healthcare space. I have the unique opportunity to work at Grady Health System in Atlanta, where I work with Dr. Lisa Flowers, and we run a co-testing clinic, and we provide cervical cancer screening and education to underserved populations. So I think we're doing a great job when it comes to preventative measures within the women's health space, but I think we can do a lot more when it comes to the maternal health crisis that we are experiencing throughout our country.
Excellent point. And we will talk a little bit later in discussion about maternal health specifically. But one of the things I also want to make sure that the audience recognizes, both here in attendance and if anyone's watching online later, is another misnomer, this concept that women's health is only the 5% of recognized diseases that are specific to women. Women's health is more comprehensive than that. And as we think about women's health overall, that other 95% of diseases, many of them, medicines work differently from a chemical standpoint because of the differences in female biology versus male biology. A number of disease states that are out there, women make up 51% of the US population, but in some instances, 60 to 70% of certain disease states, thinking autoimmune conditions, mental health conditions, most notably among them, do over-index with females. So, Nicole, as I think about Organon, it's a company you had mentioned dedicated to women's health, and the vision overall is not just to focus on, again, those 5% of recognized diseases, but also comprehensive viewpoint of women, and I believe I have it here. A better and healthier every day for every woman is the vision, is the mantra that you at Organon have, which clearly considers women's health beyond those handful of disease states. So as you think of your place in the organization as a whole, rather than thinking through brands or brand marketing, how is Organon, how are organizations like Organon, how are they working to address systematic challenges that are out there that can represent barriers to care, regardless of the disease states of focus, but certainly for the women's health, the women that you try to serve and aim to serve with Organon as an organization?
Yeah, so I love broadening that definition of women's health. And at Organon, the way we define women's health is conditions that are unique to women, disproportionately affect women, or affect women differently. So when you look at it from that lens, there are lots of therapeutic areas that need to be looked at through, a women's health focus. And in terms of systematic issues, there are many of them, but I think one of the biggest ones continues to be access to healthcare in general and access to medications, and that's, a key pillar of Organon's ESG kind of policies and focus. From a contraception standpoint, which we have, contraception medications within our portfolio, Organon is very committed to preventing unintended pregnancies. There are a little less than 50% of pregnancies in the US and worldwide that are unintended, which equates to upwards of 120 million unintended pregnancies annually, which I hear these numbers all the time and they're so shocking to me. And there are, 19 million women that live in contraceptive deserts and don't have access to that care. So it's a big focus for the organization. There are global programs in place where we're trying to prevent 120 million unintended pregnancies by 2030, and those are global programs in place. But specifically within the US, we have a program called Her Plan is Her Power that program provides grants, product donations. We have partnerships with historically Black universities that have, student ambassador programs around reproductive health to try and educate the students. And beyond that, on the commercial side, we have a lot of programs in place, and I sit within the commercial organization, and we have things like HCP locators that can help people find access to care for our products if they're interested in them. We do a lot of partnerships with physician spokespeople, with patient and physician influencers to really build that education and awareness and get broad reach for it. And then from a policy standpoint, our policy teams are really focused on education at the federal and state level.
That's fantastic. And I would encourage individuals to go to the Organon website. One of the things I love so much about those programs is you guys have the receipts. You show progress reports. You publish data that shows the impact that those programs are having. So you guys aren't just saying that. You're living it. You're breathing that message, that mission, and then showing what can be done to affect change positively within those areas that you guys are investing. Andrea, in your role, in your organization's role within media, piggybacking here on what Nicole said, these sort of above brand initiatives, these ideas, to think about education, advocacy, again, not speaking just the brand language, but overall health trends and education and whatnot. What are examples that you've seen with clients you work with that are successful in, again, forgetting about the brand world, but driving testing, driving diagnostics, driving people to get to the doctor where maybe they are lapsed and not taking enough charge of their care. So again, advocacy, education, all those things to try to get people in the door, let the product decisions be what they are, but more so motivating individuals to take charge of their health.
Sure. There's a couple things that I'll talk about here. First, there's not that many consumers that are really focused on the brand specifically that they're going to get. And I think in pharmaceutical marketing over the years, we've seen a huge focus from our clients, from our industry on trying to make sure that the brand rose to the top and brand benefits versus other brands in similar therapeutic categories are kind of the focus of the marketing messaging. But what I'll say is actually some of the most effective and most impactful campaigns over the years actually get at the heart of what the human needs are and what the questions are. And I'll use an example in actually the reproductive sector that we had nothing to do with, but it was one of the best done pieces of content that addressed a really obvious human problem in the understanding of the differences between the different therapeutic category or the different treatment options within a singular therapeutic category, and that is reproductive health and birth control. But there's such a misconception around the end user, the woman, men, doctors, even in some cases, nurses, other people. So Condé Nast, I think, actually did this piece of content, and it's old. I mean, we're talking, it's at least 10 years old at this point, but it was this beautiful piece of content out there that just showed, it was like one of those street-style interviews where a reporter was doing kind of like stopping people on the streets and saying, if I were to tell you, or if I were to ask you what is an IUD, how would you answer that? And they were just, the piece of content brought to life how little people actually knew, like forget any brands, but how little people knew what these individual, like what does birth control do? What does an IUD do? What does the pill do? What does an injection do? What does a shot do? And no one knew the answer. Not the women, not the men, not the experts. It was fascinating to see people sort of stumble through their understanding without any kind of literature in front of them, their understanding of these pretty basic treatment options. And I think what that piece of content did was help to elevate the answers to the questions without really focusing on what the brand messaging should do. And what that allowed to do was, what that allowed marketers to do was really understand how to elevate awareness around the specific things. And I think that's what above brand marketing and messaging can do, is allow people to kind of look at what the human questions are, what the human needs are, and address those, And if you're being, as a marketer, if you're being a partner and helping to actually answer the questions at hand versus being a little bit of a navel gazer and trying to continually just force brand messaging, you're gonna have a lot more relatability and authenticity to enter the conversation. I always say approximately 0% of consumers want a relationship with the pharmaceutical company, right? I mean, you work for one, you work with them. It's a necessary evil for physicians probably, but for consumers, like, it's less about what the pharma company is doing and more about who has solutions and helps me, understand different things that are going on and how do I get information, how do I learn things, and what's that journey. But above brand marketing can really help actually dissect the people's needs, the users' needs, instead of trying to push messaging and push marketing to get people to take a desired outcome. Better informed people make better decisions, and that's what above brand marketing can do.
That's great. And I do love the idea, too. We're helping them be problem solvers, right? We are adding value not because of a brand message, but through that education to understanding your options, understanding potentially risk factors, what inaction versus action might lead to, what a choice, this therapeutic choice versus that therapeutic choice might lead to. So excellent example. I really appreciate that. I want to transition here again, thinking through the lens of the 95% of conditions that aren't traditionally, quote unquote, women's health. And there are a lot of macro level factors that can lead to disparities in care. And yes, we will talk a little bit about legislation, a little bit about post-Dobbs world in a bit. I don't want to go there just yet. But focusing instead on some of the social determinants of health that can lead to different outcomes, not just between men and women, but between different subsections of the female population. A couple of stats just to level set here for the audience, which I think are interesting. Women, in many instances, particularly where it is a household, they're not just handling the care decisions for themselves. They are most often over-indexing and being the care decision makers for the other members of the household, particularly of the children. And in fact, stats will tell you about 80% of healthcare decisions within a household are being undertaken by a woman. So they are, taking care of their own health, taking care of the health of the individuals within the house. And balancing careers, balancing your own health, balancing the challenges that maybe individuals in your family face can lead to delays in care. In fact, there was a study recently where it said that women were 50% more likely than men to cancel a care appointment or have to delay a care appointment because of scheduling conflicts. And the most obvious flagged one by those individuals was childcare concerns, right? So what ends up happening if we're delaying care, all of us, but women in particular here as our focus, it can manifest itself in very real and often detrimental ways to your health. So a couple of disease states that I wanted to look at within our IQVIA data, the patient longitudinal data sources that we have that over-index with women, just to give you a concept of how this can actually manifest itself in a very real way. Mentioned mental health disorders often over-index with women. I looked at major depressive disorder, or MDD as we call it. 66% of diagnoses active at any given time, about 2 to 3 million patients within the United States. 66% of those are women. Interestingly enough, if you look at the time between the initial diagnosis and the initiation of first therapy treatment, women start therapy for MDD 43 and a half days later after a diagnosis than a man does. Moderate to severe asthma, 62% of diagnoses are women. 24 and a half day gap between when a man starts therapy and when a woman starts therapy. Even mitral regurgitation, I'm saying that wrong, you're a doctor, but you know what I'm saying. So that is a precursor to heart failure if undiagnosed or underdiagnosed. 61% of diagnoses at any given time are women. They will start over 2 weeks later on therapy than a man. So again, undertreated can lead to heart failure. So we're having these instances where we're able to get women into the doctor, able to get that initial diagnosis, but many of them are delaying therapy, potentially even walking away for therapy. So Dr. Moore, I want to return to you here as you think about the women you work with in your practice. Do some of these stats, do they manifest themselves in your professional experience? Are you seeing higher cancellations of appointments because of childcare or other factors? Transportation comes to mind as one of the social determinants of health that can lead to delays in care. And what do you feel is contributing to this? And how can we, as an industry, help alleviate some of these pain points to make sure that some of these frankly, unnecessary barriers between how quickly men end up on therapy versus women within the disease states are delaying therapy. What's causing that, and how can we work together to fix that?
Yes, I think that's a critical question, and it is one of the reasons why I came into healthcare to become a women's health nurse practitioner. From my own family system and the community I grew up in, I saw firsthand how my mother didn't care for herself first. And it led to her having a medical condition where she lost her ability to walk. She was in a really bad car accident at one point, declined going to the hospital to get evaluated. Years later, it came out that she had a bulging disc that resulted from the car accident. And she woke up one morning and just couldn't walk. So she was in extensive care for about 3 months, had to undergo surgery, did regain her ability to walk. But from that experience, I said, you know what? Women need to know that they have to care for themselves first before they can care for anyone else. It's almost like the airplane. When you're on the airplane, they tell you to put your oxygen mask on first before you help somebody else. So I said from that point on, I'm going to go into healthcare and I'm going to try to be somebody in the room that can help ensure women understand the importance of caring for themselves first. Within my respective practice, I had the opportunity to work in a variety of settings, but previously was at a FQHC back in Camden, New Jersey, where I was born and raised, and served a huge Latino population, a huge African American population. But what I would say is the high cancellation rate was due to childcare and transportation. Those are huge implications to why women are not able to seek care. And sometimes in healthcare, we label patients as, oh, they're non-compliant, but social determinants of health is real. And I always say, I'm biased here, and I'll be open to say it. I think it's becomes more of an issue for women who are primary caretakers of their household because they wear multiple hats. They have to be the primary provider, they have to be the primary child care provider for their child, bring in an income, sustain a career, so it becomes a lot. So how do we ensure that these individuals have the support they need in place in order to obtain the care that they need for themselves? So on a more positive note, at a healthcare organization in Atlanta, I had the opportunity where we provide a child care service on site. So when women come in for their pap smears or co-testing, their children are able to come, and we have dedicated support staff that are there to watch and provide child care services. That being said, industry could provide funding opportunities to various healthcare organizations that allows them to pilot a study on child care and how that impacts an individual's ability to seek certain services. I think another important thing is coupling services. So if there is an organization that has a pediatrics department as well as a gynecology or primary health women's health department, if they are able to provide some sort of support that allows for the pediatric parents to schedule the pediatrics appointment, that pediatric department have child care services, so then the mom is able to then go across to get her primary health or OBGYN services, I think is important. So I think industry can really help plug in when it comes to providing resources and funding around various initiatives and programs that allow for women to couple services. And I always bring up childcare because childcare tends to be the top reason why patients I care for are not able to continue or obtain the care that they need. And secondary, I would say transportation. I have the unique opportunity to be a part of a few funded grants with one of my colleagues where we wrote for a mobile unit that goes into rural communities in Georgia and provides cervical cancer screening. So again, we can go to the community, but we need the funding and resources to be able to create innovative ways to ensure our patients get the care that they need. So those are some of my experiences, but I think industry can do a lot of collaborations with healthcare organizations and providers that can write for funded opportunities and show outcome, show data that this works, right? And make it a sustainable solution to ensure women across the lifespan really get the care that they need. And one other population I do want to hit on is our menopause population. Menopause isn't a dirty word. It's often an overlooked population, but I always think about those populations as well. So they're finished their childbearing, right? but how do we ensure that they get into the healthcare organization to get the care that they need? So with that, I think a lot of education initiatives will be really helpful to amplify what menopause is, normalizing the conversation and discussion around it so patients feel comfortable coming in. From a public media perspective, right? A lot of populations go online for resources. So how do we target them and ensure they come into us and ask those critical questions and we have the resources for them to get the care that they need?
That's fantastic. And the panel you were on yesterday, it was very eye-opening to me at the initiation of the discussion. It was asking the women on the panel, when you started to have symptoms in that particular area, going off the menopause point, what did your doctor tell you? And it was like, they had nothing to say, or they just got out their script pad and wrote me an antidepressant. And I was like, oh, we have to be able to do so much better than that. And so I'm very glad that you brought that up, Dr. Moore. Thank you. Double-clicking on some of this, and I want to share, we're talking about women's health, we're talking about men, things that manifest differently with men versus women, et cetera. But I also don't want to make the assumption here that women are a monolith. Within women, there are subsegments of the population that negatively can see social determinants of health impact care. And this came up in some of the initial prep discussions we're here, but for the sake of the audience, I wanted to double down here using breast cancer as an example. So here's a positive fact to start with. African American women at any given time are 5% less likely than the general population of women to have a positive diagnosis for breast cancer. That's great. They are also 38% more likely to die of breast cancer. And when the Journal of Clinical Oncology dove deep into that, the primary cause of the excess mortality within that segment, again, under-indexing in diagnoses, over-indexing in mortality, was insurance issues were at the root for African American women of getting later stage diagnoses than any other ethnicity within the female population. Why is that important? Well, if you are to get a later diagnosis when it is no longer localized, you will go from anywhere from a 95 to even in some instances 99% survivability rate at the end of 5 years post-diagnosis. If it's in a later stage, that goes down to as low as 32%. So you are more likely to pass if you are diagnosed at a later stage. So when they were investigating this and they were looking at the excess mortality, they directly related 37% of the excess deaths that were caused there to lack of viable insurance, lack of commercial insurance. In fact, looking at the non-elderly women within this that had passed, they were 3 times more likely than anyone else to lack adequate insurance or not have insurance at all. So some sombering realities there for us to think about in terms of even disparities of care within subsegments of the female population not being equitable. So I'm going to turn to you, Nicole, first, but I welcome anyone to jump in on this because it is a weighty topic. But companies like yours continue to push medical innovation. That's why there's literally billions of dollars in research and development at any given time that are going on all throughout pharmaceuticals. The desire is to create better medicines. Better medicines lead to better outcomes for the patients that we serve. And again, I don't want to put you on the spot here for necessarily organon-specific examples, but as we think about that example there within breast cancer there, but there are others, the goal when these therapies come to market, these new novel active substances, is to get people on those therapies to take advantage of those better outcomes. But clearly, there are challenges that make that sometimes easier said than done. So again, above brand, but thinking as an industry, thinking of your organization, how can we navigate these? How can we put systems in place, processes in place, investment in place to ensure that essential access to healthcare is available for these critical services for as many women as possible? Well, frankly, it should be all women, but let's start somewhere and make progress for as many women as possible.
Yeah. On the manufacturing side, all companies really have market access teams that are dedicated to doing just that and looking for ways that they can get as broad access as possible for all the patients that need our products. They also work on things like patient assistance programs that help people that can't afford their medications. But part of that is patients need to know that those options exist, and those programs need to be communicated so that people know they have somewhere to turn if they're running into those, affordability challenges. And beyond that, those kinds of programs have been around for a long time. Obviously, there's more work to be done in that space, but what really excites me is this emergence of, digital health startups. At-home testing has become very possible. It's creating a lot of opportunities for patients to get care in other places. We've seen this emergence of telehealth services that are available, so I think it creates more options for patients who haven't been able to get to the doctor to access care in other places. So that's one of the things that my team focuses on, just more of these modern partnerships, and how can we look at some of these emerging startups, find companies where their mission aligns with ours, and figure out how we can work together to create more opportunities for access to care.
Yeah, I think I'll just add to that. I think access and care is really an interesting component here. Obviously, when from a marketing perspective, you're always thinking about what are the barriers to adoption, right? So in this particular case, there are multiple stakeholders. So you've got the patient; they have to make an active decision to go seek therapy, go seek a doctor's support, go seek treatment. The doctor has to agree with the patient's assessment or make their own assessment, and drive toward putting that patient on a specific therapy. And then someone has to cover it, right? And I think in women's health, especially, and what Nicole just referenced with their market access teams, of course the objective is to get as broad of access and coverage as humanly possible. But in this category, it is seriously lacking. And it's lacking across the board, and it takes a very long time from the time a product hits the marketplace. It can take a very long time for the, and I think about menopause in particular. We've worked with a bunch of pharmaceutical-grade medical products, and those products are still fighting to get access and coverage for women. So even if we can do a great job of making, getting people to adopt the concept that menopause is in fact a medical condition that you don't have to suffer with, in its entirety, there's hormonal and non-hormonal options to treat, and some in fact are prescription strength. But even if you can get a doctor who's willing to go there with you, not having coverage is a killer. So it can be years until someone can actually get that drug that came to market, got FDA approval, all of the R&D dollars and time that went into the development of that drug, and then it's like you have all of these marketing dollars invested in trying to drive the awareness of and the adoption of and the interest in these products, and then you fall short when you actually can't get access to them because they're not covered by insurance companies. So it's a vicious cycle, and I think what we've all seen is that the managed care side of this equation is a huge barrier to the success of the industry at large, because it's stalling the kind of positive momentum that the industry is trying to drive with all of the investment in the R&D, and it's just not getting there as fast as it could.
That's a very interesting point, and I appreciate that. And it's going back to some of the disease states that I had mentioned earlier, the non-women's health one, like your MDDs, your moderate to severe asthma, things like that. When we were double-clicking down on the data further, what I thought was interesting was, again, there's those gaps between women starting therapy, comparatively speaking, to their male counterparts. But then when the women actually end up on therapy for each of the disease states that I looked at, for MDD, for asthma, for the cardiovascular conditions, all of them were more persistent on therapy than their male counterparts. So we're doing what we can to get women in to talk about these diagnoses, potential diagnoses. We're getting the scripts in hand. And when they end up on therapy, they are actually better patients. They're finding out that the evidence is suggesting that they are more persistent than men. But the biggest gap, of course, that we had isolated there was the time between the script being written and then if a woman actually ends up on it, and when they are more persistent. So one of the things I think is important there, and this is diving into a little bit about a little bit more of the macro, but if you look at the data at any given time, and some of this is access related, some of this is insurance related, we're in a situation now with a lot of these medicines because these new and novel therapies tend to be more expensive because, again, all of that R&D, Andrea, that you just mentioned that goes into it, that investment does need to be recouped, where less than 50% of scripts that are handed out by individuals like Dr. Moore, those people end up on therapy. And of those that do end up on the therapy for chronic conditions where you're supposed to stay on it for a long time, only about 16% of those people that get the script at the end of year one are on that therapy, which is a huge gap when you think about it. Again, we're investing all of this money to get people to walk out of the doctor's office with that script in hand, but at the end of a year, 16% of people are still on that script if they're supposed to be on it. And it's interesting because costs can play a huge role there. A lot of the cost burden, unfortunately, in the United States does get passed to the individual. What our data shows is that the second the out-of-pocket cost in a month goes above $75 for a patient, triple the abandonment rate, triple the primary non-adherence, which means you have the script and you walk away from it without some sort of assistance. And I think that affects women disproportionately because all of the evidence shows that in any given year, and this does factor in maternal care, so it does help to drive the cost up, but the cost burden from an out-of-pocket standpoint on women in the United States versus men is $15 billion. That's billion with a B, $15 billion higher each year for women than men. Even when you back out the cost of maternal care, more traditional non-maternal disease states that we're all dealing with, again, those 95% of diseases, the cost burden is still $250 to $300 more a year on a woman than a man, which seemingly is ludicrous, to me at least. So as I think about it, Andrea and I worked together for an awful long time. I was at PHM for a while. And one of the things back in the day when, again, we work with a lot of brands, we still do, new patient starts. That was always what we were tracking towards. Get that person to walk out of the doctor's office with a script in hand and we're considered a success, right? But as healthcare dynamics change, notably access, et cetera, and you're seeing half of those people or less end up actually starting that therapy, the dynamics really have changed from a healthcare standpoint. So I'm curious, as you work with clients now, are you more cognizant of the entire patient journey, not just new patient starts, new scripts, all those things, but assisting patients navigating hurdles that help them begin therapy, adhere to therapy, stay on those critical drugs? And are there examples that you have that you've been working with clients where you're creating initiatives, helping to with the media get the word out there to support these initiatives to hopefully get as many people actually on the therapies that someone like Dr. Moore hands them? They walk out of the office. Let's try to get as many of those people to actually end up on the therapy and stay on the therapy. Are we seeing the industry move more towards those types of messaging and content and resources for individuals?
Yeah. So first, I blame you and I for the industry's focus on, the obsession with new patient starts, because it is, while it's an important economic part of the story, of course, because you have to validate the investment that the organization's making in marketing dollars and why those dollars are turning, helping the organization to recoup those investments. It is a very actually small part of the total story. The data can, should, and is a storyteller. So it's a storyteller predictively, it's a storyteller along the way, and of course it's a storyteller in terms of validating or invalidating a hypothesis, which is what marketing is. It's a hypothesis as to how to kind of relate to a patient or a provider and figure out how you can change behavior. But some of the data that we've seen, I think, over the years that's actually been more useful, because all you can do after 3 months or 6 months, however long it takes you to validate the investment dollars, right, is just know whether what you did was good and know that you can tell the organization that money that they spent was worth it, right? So that's really that's the biggest thing that you can get out of that part of that metrics and that story and that narrative. But to a point, it's kind of late to do anything. It's kind of late to understand exactly where you should pivot, the kinds of profiles or patients or providers that you should be reaching, the differences in behaviors around different segments and different types of targets. And Nicole, we've talked a lot about the importance of nailing the actual audiences and the value strategies within each audiences. But data is a way to help you understand much more about what you should do and also alternatively what you shouldn't do. And I think it should tell us a whole lot more, and it can tell us a whole lot more. So when you put together your kind of KPI roadmaps, if you will, or your data strategy, how you should be looking at that stuff. It's really important to actually think about, of course, you're going to look at the ROI production and like making sure that the organization at the CFO level can feel really confident that these dollars are dollars well spent. But also, your marketers and the teams on the field, you need to know how to change your strategy. So on the field, you need to know, which audiences, like if you spend more dollars in certain audiences, who's going to accelerate faster? What are the barriers to adoption? What are the barriers to movement? What are the accelerators? Where are the things that you're going to be able to actually make impact and how to do it fast? So the fast metrics are becoming much, much more valuable. And depending on the type of category, it goes even beyond that. It goes beyond the audience segmentation. When you're trying to grow a category, and as you were talking about menopause, would you just drive people into providers with more information? But there's a huge curve of time under that period where you're actually having to build awareness in new ways, like build new information, build new editorial, build narratives for people to read to make them start to change behavior. And some of the metrics don't even have anything to do with the hardcore data, like IQVIA data. Some of those metrics are like, are we changing? Do we see more people searching for menopause treatments this year than we did last year because we've invested dollars in building awareness that there are pharmaceutical grade treatments for menopause? So can we see the fact that we've driven actually more behavior and more intention around seeking out that option, whereas a year ago, before people were aware that there were pharmaceutical grade treatments, nobody was looking for it because everybody just assumed it was the side effect of aging. So the stories are in the data, and the data needs to tell kind of that comprehensive story of what it is that we're affecting, how we can affect it, what we can do better, what we should stop doing, and how to prioritize those investments.
That's great. Nicole, there was a head nod there to some of the ways that you guys have partnered together. So I think that's a natural way. Where you sit within the actual manufacturer at Organon, what are some of those initiatives that you guys are sponsoring to make sure that we are solving for some of the real challenges that are, again, forgetting the new patient starts, but all of the other data points that we need to foster, all the behavioral change we need to foster, what are you seeing out there that are, effective ways that organizations can help patients that come into Dr. Moore's office and others, overcome those challenges, overcome those barriers to get on therapy, stay on therapy for, the potentially life-altering and life-changing therapies that organizations like yours bring to market?
Yeah, I know I spoke a little bit to partnerships earlier, but this is a space where those partnerships really are so important. As a pharmaceutical manufacturer, we are experts in developing and manufacturing and commercializing products, but we, aren't experts in app development and management. So there are so many companies now that are, like digital health companions, refill reminders, really in-depth adherence programs that make it easier for patients to be reminded to stay on therapy. For example, and this one's in the public domain, so I can talk about it, but we have a partnership with Sempre Health, which is a company that essentially works with individual health plans to create this kind of tiered copay structure and refill reminders. So someone can go to the pharmacy, their copay is $25, and the next time they refill it, if they refill it on time, their copay is $20. And as they continue, it kind of has that financial incentive. So there are tons of companies like that are, out there now that we can work with to build on the adherence.
I think what's cool about that as well, this industry is not known for being ahead of the game, right? I mean, this industry, as an industry, we don't think we're the most innovative. However, I do think that that's a misnomer. I think there's more red tape to kind of go through to get to innovation. And what I like about the industry and what we're trying to do right now is to learn from industries who can move a little faster, based on less regulatory hurdles, of course, but learning from areas like the retailization of healthcare and seeing all of the startups crop up, I think is is a really interesting and promising trend for the industry overall in terms of how manufacturers like yourself and just general, health tech startups that are focused on making it easier for products to get in the right hands and making it easier for people to access the care that they need. I think that's an incredibly positive advancement in the overarching space, and how, consumers' expectations are obviously being set well outside of healthcare. So if you think about all of the retailers, and like what retailers do best is they know what's going to motivate you. They know how to identify their consumers and put the products in front of you that you're likely to be attracted to, and they make you feel like they got you right at the right time as you were just thinking about that bag you wanted to buy, or those shoes you wanted to buy, or that shampoo that you definitely didn't need but now you definitely need. And they do such a great job of not only putting the messaging in front of you but making the transaction super easy, and taking the friction out of the entire experience. And I think as the pharma industry and healthcare overall industry learns from that, we're going to see some of these barriers hopefully be alleviated, or at the very least, addressed in a positive way, which I just think is a nice evolution to start to see in companies like Organon, who are investing in innovation. Like the point of that is to how you develop those partnerships with those organizations that are going to take you out of the original or the standardized playbook, and think about the ways to use those types of technologies and those types of advancements in positive ways that are going to help get patients to care faster.
Yeah, and to that point, I think adherence is an area that's so primed for predictive analytics, and being able to take advantage of the technological advances and analytical advances that we have, and look at those who are likely to drop off therapy, and deliver interventions before they even get to that point. So, very excited about all of the analytical capabilities that are out there.
Love it.
So we are coming close to the end of our discussion here today, and I hopefully we'll leave some time for Q&A, but if we run out of time, we'll certainly be here in the room thereafter. I want to bring it home here, and this is a weighty topic, but I think it's important and certainly near and dear, Dr. Moore, to your heart and to all of ours, which is to discuss how the current political and legislative climate is having an effect on women's health, reproductive health in particular. It would be disingenuous of us to not call out right now. We're sitting in the state of Texas. Texas in 2022 had a law, went into effect in July of that year, taking away a woman's right to choose, taking away elective pregnancy termination. Dr. Moore, you practice in Georgia. In and around that same time, a law was passed in the state of Georgia that outlaws those procedures after 6 weeks post initial conception. So again, I sit at IQVIA. IQVIA houses patient longitudinal data sets. Data helps us tell a story. Data helps us contextualize those things. What did we see in and around that time when that legislative action was happening in a post-Dobbs world? Overall, with medicine, the number of patient days on therapy between 2022 and 2023 actually went up 3%. So again, more medicines in market, more novel therapies. That's great. What did it look like for reproductive care? Over that same time, the average patient days on therapy for pregnancy prevention, contraceptive patient days on therapy declined by 15%. At that same time, more permanent procedures such as sterilizations, those were seen to be up 10, 11, 12% over that time period. So I really want to drive this home, and Dr. Moore, you're in a very unique position where you sit because you were within practice before, during, and after this seismic shift. So for our audience, can you give us some insight into complexities that have been added to your ability to provide optimal care in these areas to your patients, and how that change within the state of Georgia has affected your day-to-day ability to give the best possible care to your patients, particularly in the reproductive health environment?
Yeah, so I want to start off by saying Happy International Women's Health Day. Yes, it's a great day to have this discussion, and I think for the patients that I serve and care for, it's important for them to understand that just being a woman is important. Your value, regardless of what's happening on a political landscape, just your existence is enough. And it's enough for me as a healthcare provider to advocate for you and to ensure I'm able to provide the adequate care that they deserve. I saw some pretty ugly things in healthcare post-Dobbs decision, and it was very disheartening as a healthcare provider to be limited to the practices that you know are evidence-based that you no longer can care for. And I was very in a unique position because I came from Philadelphia to Georgia, and laws are very different there, and the scope of practice is very different. So it was very hard for me to process being able to provide certain services in the state of New Jersey and Pennsylvania, and now I'm in Georgia, and it's very different now. So how do I best support my patient in navigating this new landscape, right? And I'm always one that is optimistic. There's always a solution. We just have to figure out what's the best path forward. So for me, it was me having a greater understanding as a healthcare provider what my limitations were based on the restrictions. 2, how do I support my colleagues in understanding how do we help our patients then navigate this new system, and having resources readily available to our patients on site to connect them to the care that they need. That took some time. It took a lot of processes and programs to put in place, resources to put in place, but I say collectively as a healthcare team, we were able to do so through national organizations that were able to provide us with resources as well. But I always say any restriction on reproductive health care, including abortion care, hurts women. It harms our patients. And I unfortunately witnessed a lot of unfortunate outcomes and learned of very disheartening stories because of that decision. And the other thing I would say is it really has taken a hit on the patient-provider relationship. So from my lenses, that's one of the most critical relationships that you can have with your patients, is one that is trust. And when you have misinformation, when you have constant changes to healthcare, patients tend to stay away because they don't know, can I trust my provider? Can I trust what they're saying, that they're going to lead me the right way? So for me at that time, and still always, is ensuring my patient feels as though they can trust what's being said, that I have the information that is up to date that can really help support them during this new landscape. Because both from a patient and provider perspective, it was a very different place for us to be in. But I think it's always important as providers to be solution-driven. Yes, there's changes across the country when it comes to access to reproductive health care, but what are we going to do about it? And for myself and my colleagues that I work with, we look for solutions for ourselves and our patients, and that's really ensuring that our patients leave with what they need and they're connected to those services before they walk out the door. Not that, oh, we'll give you a call in a week to tell you. No, the patient needs to know exactly where they're going before they leave the office so that we ensure continuity of care. But overall, from my personal lived experiences with patients, there was a really horrific time for healthcare during the post-Dobbs decisions, and it's still a very hard time post the Dobbs decisions. But I take that path of solution and positivity, and what are we going to do about it? How are we going to support our patients getting the care that they need, even if we can't provide it within our state? How do we connect them to other providers at neighboring states that may be able to provide them with the care that they need?
I really appreciate that perspective. And as I talked about at the top, if hearing something like that, everyone in the audience, if that doesn't make you just furious, you just channel that anger, channel hearing the pain from some of those stories, the lived reality of some of those women within your practice and others that were affected like that. Put that into advocacy, put that into what you are thinking through when you pull the lever at the ballot box. These changes are, not to get on a political soapbox, but just absolutely unacceptable as far as I'm concerned, and I'm sure everyone sitting here today thinks of that as well. What those changes and those challenges have done, too, is it's taken 35% of counties within the United States and created what you had referred to earlier, Nicole, you had noted this, as maternity deserts. There is no access to OBGYN care. What ends up happening there is you then have a lack of residency applications going to those areas, so that will only exponentially exacerbate within those counties the lack of adequate care for these types of situations. What that does then is it puts a burden on individuals, nurse practitioners, healthcare professionals, doctors, et cetera, in general medicine, internal medicine, that now find themselves in those 35% of counties in the United States having to handle conditions and care decisions that they were not educated to do. So I want to touch on this quickly, both Nicole and Andrea, because I think there's a role that media and brands and organizations can play. But this also has had a change on the communication strategy and the education strategy, because it is no longer your 10,000 target list of OBGYNs. In some of these areas now, you're talking to gen med, you're talking to internal medicine, individuals that have an education gap that needs to be closed, and closed quickly, to make sure that the right care is being given by practitioners that are no longer available, so the burden is now falling on other doctors. So care to comment? And we only have about 5 minutes left. I know it's a weighty topic, but quickly, how does that change your strategy in who you need to talk to? And Andrea, how does that change the strategy of how media can help solve for some of those educational gaps that became a very real reality for doctors who, pre-Dobbs being overturned, maybe were not thinking of these medicines, of these procedures, of these diagnoses that now are a part of their daily routine?
Yeah, with this, fragmentation of provider choice is kind of how I would describe it. We have had to fully shift how we're communicating to healthcare providers. And, historically we would promote to OB-GYNs, and now we focus a lot on providers in the primary care space and family practice that we didn't have to do before. And I touched on some of the predictive analytics, but we've really invested a lot in our analytical capabilities and factoring in, beyond just provider behaviors, prescribing behaviors, account behaviors, adding in state policy information into our algorithms, because it is so variable now when we look across our customer groups, and we need to make sure we're communicating appropriately to all of our different customer segments. So that's been a pretty significant change that we've made.
Yeah, and from a media perspective, I mean, the first step is defining who you're reaching, right? And as Nicole said, it used to be very obvious based on the the label of the clinician on the other end of the receiving end. But actually, the first step is figuring out the relationship between patients and providers across different related world or adjacent specialties, because we are seeing PCPs, general med, internists, et cetera, play different roles in different types of therapeutic categories that are traditionally assumed to be handled by specialists, and they're just not. And whether that's geographical or relationship based, it's tough. But as Nicole said, when you invest in some of these AI products that can be more predictive and can help understand not only what someone was trained to do and what their title says that they are, the type of doctor that they are, but actually which types of treatments are happening in which offices based on the populations around them, based on the providers within them, based on the relationships within a given office, private practice versus, the bigger commercial institutions. But how are all of those data points can help you really understand where, different therapeutic areas or different products or different competitive products or whatever, it can help you understand where those transactions are happening, so you can focus your investments and your priorities and your comms more in those areas because you know more. So knowing more about, being understanding about the fact that it is more of it's expansive versus reductive in terms of where those treatments are happening. Of course, then you also have to contend from a attention perspective. If you're talking to someone like they're an OB-GYN, but they're, an internist or general medicine, and they're responsible for everything under the sun on that patient's, healthcare card, you might only get 1 minute out of the 7 that they might spend with that patient. So it's a harder communication strategy when you know that you're not dealing with an expert who has to kind of consider that plus all of these other things. So it's knowing who they are is a great start, but understanding what to do once you know who they are based on everything else on their dance card, I think is also equally important.
Yeah, and the only other thing I'll add is we've been having to collaborate much more closely with our policy colleagues to scenario plan, understand the possibilities of what could happen, and make sure we have plans against those things to serve our patients the best that we can. But that collaboration has become more critical than ever before.
Great, I appreciate that. So we have 1 minute left according to this big red clock that I can see that you in the audience cannot. So I want to give you, Dr. Moore, the final word. We talked about a lot of heavy topics today, but one of the things that you kept saying, which I love, is being solution-oriented. Rather than looking at it as a problem, looking for solutions, finding that hope, finding the way to connect people to the care that they need. So you are, first of all, thank you to all three of you for joining, but you, Dr. Moore in particular, because you represent really at this health crossroads where we are within your practice, particularly in women's health, giving you the final word. How is it that we as an industry and anybody in the audience here today, how can we help you do your job better to help the patients in your practice that deserve the best care possible?
So I think it's really understanding we all have the power to do something and really tapping into our respective organizations to understand what you can do to contribute to change. From my perspective, if things are made easier for me to ensure healthcare for my patients, it typically will make it easier for my patients. I'm a big person when it comes to AI, data, apps. I find them very, very useful when I'm counseling patients, whether that be on a disease process or a medication. Most of the patients I care for have access to a phone and technology to be able to easily translate that information. And one example I'll give you is the organization that creates the PAP screening guidelines. There's an app that I can pull up when my patient needs to know what their results are and what are the next steps in their management of care, right? But the app makes it so much easier. So I always say, Nicole, you mentioned various programs, but if there was the ability for industry to develop technology that eases education around disease processes, both from a management and prevention perspective when we're talking and managing care for our patients, would be very useful. When it comes to drug modalities and treatments, sustainability, affordability, accessibility is important. So ensuring when drug modalities and treatment modalities are developed, ensuring that the patient can be sustained on it for a longer period of time or the period of time that they need it. I'll tell you personally, if there's a medication or a treatment that comes out that I know my patient can only afford for 3 months, is it worth me giving this patient this great aha for 3 months and then telling them because your insurance doesn't cover it after and because this organization really doesn't have a system in place that allows you to continue on it, would that be the best option for me to give the patient? In my instances, no. I'll go with the secondary choice that I know is still beneficial, but the patient can sustain it over the period of time. So the 3 things I always say: listen, whether that be to healthcare providers, consumers, collaborators, and partners. Validate what's being said, but most importantly, do something about it and understand you have every power within your organizations to come up with a solution right where you are.
Thank you, Dr. Moore and Andrea and Nicole for joining us, and thank you everyone here today. We really appreciate your time. Take care.